5, 4, 3, 2.
Hi, everyone. I would like to welcome you again in our journal club sessions. This time we have the second pulmonary pathology session. It's a slide seminar-based cases. And we have the speaker, Dr. Andraskor, with us. He is a colleague from Mayo Clinic. This is the second time actually he's joining us here in Abu Dhabi. Dr. Andras, he's a pulmonary pathologist, did his fellowship in Mayo Clinic in Rochester, and he then moved to the Mayo Clinic, Florida. He was the chair for a period of time. He had more than 80 peer-reviewed publications, and he wrote more than 20 book chapters. He is part of the editorial board of the Archive of Pathology and Laboratory and Human Pathology and Pathology and Oncology Research. So without any further ado, let's welcome Dr. Andraskor. Welcome. And yes, please.
Thank you, Dr. Rabia. First of all, I'd like to thank Dr. Abba, Dr. Iman, and Dr. Rabia for this kind invitation. This is my second time at SSMC and Abu Dhabi, and I'm really happy to be here again. So I'd like to start my slide seminar. So this is a somewhat new format. We are going to use scanned slides, digital slides in my presentation. And please make this very interactive. I would be happy to answer questions anytime during the presentation. Hopefully you have also received links and histories, and if you click on those links, you can go to the slides that we are reviewing, and you can do this. If you haven't had the chance to do this before the presentation, you will also have a chance of doing this after the presentation. I will also share a copy of the presentation with you after we have completed the slide seminar, and Dr. Rabia will be kind enough to help us with that. So after
they can see that in the website of the Journal Club, the presentation.
Excellent. So as Dr. Rabia says, you can find the presentation on the Journal Club website. So I'm a pulmonary pathologist, so I'm gonna show examples of various non-neoplastic and neoplastic diseases in this presentation, which probably gonna take about somewhere around 1.5 hours total. And again, I will be happy to answer questions either during the presentation or after the presentation. So let's start with the case number 1. This is the case of a 54-year-old male who underwent right single lung transplantation for a diagnosis of pulmonary fibrosis. And I will give you a little bit more history once we have discussed the case. So as you all know, for interstitial lung diseases, it's very important to review the chest CT findings. In this case, these are pre-transplant chest CTs. on the right side, you would see the CT images, and on the left side, obviously the description by the radiologist. So this chest CT shows multifocal ground glass opacities, which is a type of opacity when you can still see the margins of vessels and airways in the background, as opposed to consolidations where margins of vessels and airways are not seen anymore. In addition to this these hazy ground glass opacities, we also detect coarse reticular interstitial fibrosis. When the radiologists talk about reticular patterns, it translates to fibrosis in our world of pathology. In addition to these lines of fibrosis, there is also a honeycomb change, which is several cystic spaces adjacent to each other, and it's the end stage form of fibrosis. There are some larger cysts as well, not typical honeycomb cysts are a little smaller, but sometimes you do see a larger cysts in advanced fibrosis as well. And in this inset, you see the level of the CT scan. If you look at it at this level, the right lung is completely fibrotic already, but if you look at the left lung, there is some peripheral fibrosis, but there is also some areas of relatively normal lung in the center. If we go a little lower, then at this level, again, you can see the level in the inset, and then the fibrosis is more advanced on the left side as well. So the chest CT shows advanced fibrotic interstitial lung disease. So let's look at the slide. So again, we are trying this new format when we actually show you actual digital slides. So at this low magnification, the lung is almost entirely obliterated by fibrosis. There is advanced fibrosis throughout the sections. There might be there is some microscopic honeycombing, which is basically cystic spaces surrounded by fibrosis for a pathologist. But what we also need to notice, although it's not that striking in these sections, that there are also relatively well-preserved areas of the lung. When we see this kind of variegated appearance of a fibrotic lung disease, then the first thing that we think of is usual interstitial pneumonia, which, as you will see, is a histologic pattern.
How about those dilated bronchi, and just like a secondary features?
So that's a very good question. The airways, the bronchi. So this is a bronchus, obviously. The reason we know that is because there is cartilage. Bronchi are distinguished from bronchioles by the presence of cartilage or submucosal gland. So as Dr. Ravia pointed it out, this airway is very much dilated. Dilatation of the bronchi is also called bronchiectasis, and when it is associated with fibrosis, then it's a secondary phenomenon called traction bronchiectasis, when the shrinking lung pulls the airway apart and creates bronchiectasis. So that's a very good question. So we also have that. Now, when we suspect usually interstitial pneumonia, then we also look for another feature, and that other feature is the so-called fibroblastic foci. So the fibrosis here is mostly pink, which is advanced collagen fibrosis, but we also have these so-called fibroblastic foci, which is myxoid fibrous tissue, and that represents younger fibrosis. And in the case of usual interstitial pneumonia, that's the leading edge of the disease. You usually find fibroblastic foci at the interface between advanced fibrosis and the relatively normal lung. So all these features, again, advanced fibrosis, patchy areas of normal lung, and the presence of fibroblastic foci suggested that we are seeing a pattern of usual interstitial pneumonia. Now, we have to look at it a little bit more closely to see whether there are. So just step back one step. When we see the usual interstitial pneumonia pattern of fibrosis, the most common underlying etiology is actually unknown, and it's called idiopathic pulmonary fibrosis. However, there are other underlying causes that can lead to the same histologic pattern. So we have to investigate a little bit to make sure that we are not dealing with one of those entities. And in this case, if we move a little closer, then suddenly we see these type 2 cells, hyperplastic type 2 cells, which have vacuolated cytoplasm. That's a feature that you wouldn't see in a case of idiopathic pulmonary fibrosis, but it's something that's very unusual, but at the same time is very characteristic. So if we had more audience in this room, I would ask what your diagnosis would be, but I guess we are just gonna move ahead and show you the diagnosis. So again, I have to go back to my presentation, and the diagnosis is Hermansky-Pudlak syndrome associated with usual interstitial pneumonia. This is a very rare disease, as you will see, and we had this patient transplanted at Mayo Clinic in Florida. So let's have a little discussion about this case. First, about usual interstitial pneumonia. So usual interstitial pneumonia is a radiographic and a pathologic histologic pattern which is characterized by its variegated appearance. So on the right side, there is a gross specimen showing usual interstitial pneumonia pattern. And it beautifully illustrates the key features of usual interstitial pneumonia, namely advanced fibrosis, which seems to be grayish here on the picture, with some cystic spaces, also known as honeycomb change. And most importantly, we also have preserved areas of lung tissue, which look more brownish in this specimen. So this kind of variegated appearance is the key feature of usual interstitial pneumonia. In addition, the distribution is also important. The fibrosis is usually subpleural and along the interlobular septum. So what we saw in the gross picture, we also see microscopically. There is advanced fibrosis, mostly in the periphery of the lung, in the subpleural area. There is also some honeycomb change, again, cystic spaces surrounded by fibrosis, but there is also well-preserved areas of lung tissue. And again, when you see this kind of variegated appearance, you also would like to see fibroblastic foci, which are typically occur between the advanced fibrosis and the normal lung tissue. And it's represented by this myxoid fibrous tissue, which is in the interstitium. We are not going to talk about organizing pneumonia today, but I would say that much that the plugs of organizing pneumonia are similar to fibroblastic foci, but the location is different. Fibroblastic foci are interstitial, as you can see it here, whereas the fibroblastic plugs of organizing pneumonia are in the air spaces.
We don't have a good number of attendees. If you want to ask them, maybe they can write their answers when we come to diagnosis. Yeah, so anytime you want to write to us, just do so, and we are try to answer your questions to our best of our abilities. I hope I will see when there is a question addressed to us. So, as I mentioned earlier, usual interstitial pneumonia is a histologic pattern, and the most common underlying diagnosis is idiopathic pulmonary fibrosis. So most of these cases do not have a known etiology. However, there are other disease processes that can end up with the same histologic picture. And some of these have characteristic features that would suggest that what we are seeing is not idiopathic pulmonary fibrosis, but something else. So, for example, if the UIP pattern is induced by a connective tissue disease, then we often see lymphoid follicles. Actually, it's a very characteristic feature of a connective tissue disease to see lymphoid follicles. So if the patient doesn't have that diagnosis of a connective tissue disease, then the clinician should investigate in that direction. Some of these patients do not have a full-fledged
connective tissue disease, and some of those cases are actually called interstitial pneumonia with autoimmune features, or IPAF. Another entity where you can see a usual interstitial pattern is fibrotic hypersensitivity pneumonia, where poorly formed granulomas can lead us to the right diagnosis. Asbestosis is usually represented by asbestos bodies. And finally, in the Hermansky-Pudlak syndrome, vacuolated type 2 pneumocytes can point us in the right direction. So a few words about the Hermansky-Pudlak syndrome, or HPS. It's a rare autosomal recessive disorder. It's described by Hermansky and Pudlak and at Charles University in Prague in 1959. 11 types of Hermansky-Pudlak syndrome are known these days, and these 11 types all have different mutations. So 11 types, 11 different mutations with 11 different genes. The prevalence is not, in general, is rare, but in some areas of the world, some certain populations more commonly see this syndrome. For example, in Puerto Rico, particularly in the northwestern region of Puerto Rico, 1 in 1,800 individuals have are carriers for the mutation, and 1 in 22 individuals are actually have. I'm sorry, 1 in 1,800 individuals have the disease, and 1 in 22 individuals are carriers of the mutation. What are the clinical manifestations of this syndrome? They present with albinism and also bleeding disorders. There are some organ involvement in some of the forms of Hermansky-Pudlak syndrome as well. Pulmonary fibrosis occurs in HPS types 1, 2, and 4, and granulomatous colitis, which is similar to Crohn's disease, occurs in HPS types 1 and 4. The histologic features, as you have already seen, include usual interstitial pneumonia, and also the presence of these nice vacuolated type 2 pneumocytes. We also gained additional history from this patient. He was born in New York, but both of his parents were from northwestern Puerto Rico. Well, this disease occurs more frequently, and he does have features of albinism as well as platelet abnormalities consistent with this syndrome. 9 years after lung transplantation, so he had a right single lung transplantation. The patient is still alive. He does have chronic lung allograft dysfunction, and due to the immunosuppression, he also had skin cancers. So this was our first case, and I'm happy to entertain any questions you may have. Have you received any questions, Dr. Ravia?
Yes, I do have one. what about the accumulation of intra-alveolar macrophages in the air spaces? Are those associated to squamative changes?
So that's a very good question. The air spaces do contain some alveolar macrophages. It's a rather non-specific finding in most of the cases, but for some of the interstitial lung diseases, more specifically for some of the idiopathic interstitial pneumonias, actually the presence of our macrophages in air spaces is rather characteristic. So there is an entity called respiratory bronchiolitis. That's a histopathology pattern characterized by alveolar macrophage accumulation in and around respiratory bronchioles. When it is associated with symptoms that cannot be explained by anything else, we call it respiratory bronchiolitis, interstitial lung disease. So again, in respiratory bronchiolitis, interstitial lung disease, or respiratory bronchiolitis, the alveolar macrophages are accumulated in and around respiratory bronchioles. When this respiratory when this alveolar accumulation is more widespread, then we are talking about desquamative interstitial pneumonia, which is another typically smoking-related interstitial lung disease, more specifically one of the smoking-related idiopathic interstitial pneumonias. Now, as I mentioned before, alveolar macrophage accumulation by itself is not specific to any disease entities. You can see it in other conditions as well. And we often call those desquamative interstitial pneumonia-like reaction. You often see it in an adjacent to fibrosis. And I believe in our case, that was the case. So the alveolar accumulation, alveolar macrophage accumulation was a non-specific feature associated with this fibrotic interstitial lung disease.
Well, there is another questions that keep coming for the same case.
Excellent.
All right, so we have one question. Are vacuolated pneumocytes specific for Padlock syndrome, or can they be seen in other conditions as well?
So that's another good question. When these vacuolated macrophage, vacuolated type 2 cells are associated with the background pattern of usual interstitial pneumonia, then it's a rather specific finding. But we do have, we can see vacuolated cells, particularly vacuolated macrophages in air spaces in other conditions as well. One specific condition that comes to my mind is amiodarone toxicity. So in amiodarone toxicity, we often see vacuolated cells. Those are not vacuolated type 2 cells, but vacuolated macrophages, and they are not lining the alveoli, but they are actually in the alveolar spaces.
Good. So let's move on. That's for the first case so far.
All right. So the second case is a 65-year-old female with a history of scleroderma. And as so many other patients with interstitial lung disease, she presented with dyspnea and exertion. And again, as I mentioned before, the chest CT is very important. So let's look at some chest CT scans here. The chest CT shows diffuse interstitial fibrosis. You see these lines of reticulation. Sometimes these lines of fibrosis intersect each other, forming small nodules as well. So it's a so-called reticulonodular pattern. And again, similar to the previous case, the disease is more severe in the lower lung fields. One thing that is missing here as compared to the previous case is honeycomb change. So we don't see those cystic spaces that we saw in the other case, which represent honeycomb change. So fibrosis without honeycombing. So let's see in the histologic section. That's it. So if we compare this low magnification view with the previous case, then what you have to accept is that this fibrosis or this lung disease is much more uniform than the previous case. So when we are talking about uniformity in relation to interstitial lung diseases, this is what we mean. It doesn't necessarily mean that every septum is of the same thickness, but what it means is that we do not see advanced fibrosis and relatively normal lung, but everything seems to be of the same age. So let's get a little closer to convince you that this is truly the case here. So this alveolar septum is thickened by fibrosis. And if you move around, almost all alveolar septa are thickened. Even this one is, although it's a little thinner, but still involved by a little fibrosis. So it's relatively uniform. And when we go to the periphery of the lung, it still looks pretty much the same. It might be, the fibrosis might be a little thicker, but we do not see any much difference in the quality of fibrosis between the center of the lung and the periphery of the lung, and the presence of honeycomb change is really not characteristic of this patient's lung disease. So I understand that some of you would say that oh, this is not entirely uniform, but you have to accept that when we talk about uniformity in interstitial lung diseases, this is what we mean, and hopefully the previous case was contrasting enough as compared to this one, so you accept that concept, that this is a relatively uniform lung disease. So what else can we see here? There is definitely some fibrosis, and there is some mild chronic inflammatory infiltration also in the alveolar septa. But again, the most important feature is this relative uniformity. And of course, the presence of fibrosis is also important. As we scanned this case, we didn't see any specific feature that would steer us to In other direction, there are no granulomas and other features present. So again, the question is what the diagnosis is. So if you remember of the patient's history, she did have a history of scleroderma. So if there are no answers coming in, then I would let you know that our diagnosis is okay. We are going back to here. That's the beginning. No.
Yes.
Here we go. So the diagnosis is scleroderma associated nonspecific interstitial pneumonia. So this is another.
Yeah, we have people here. We have Dr. Najla and Dr. Shaza got it right. Correct diagnosis.
Oh, perfect.
They wrote it, yeah.
Perfect. Very good. We can maybe remove that. This, sorry. Okay. Thank you. Perfect. Thank you. We can move that. Excellent. Thank you. So, thank you. I'm glad we have some diagnosis here, and they were also correct. So the diagnosis is scleroderma associated nonspecific interstitial pneumonia. So what do we know about nonspecific interstitial pneumonia? First of all, it's the name says nonspecific, but actually the histology criteria are rather specific. So we are not talking about a waste basket, but we are talking about a histology pattern that has rather specific features. The first and most important feature is that the lung is uniformly involved. So again, if you don't remember anything else from this slide seminar, then hopefully you will remember that the usual interstitial pneumonia is patchy. It has a variegated appearance, whereas nonspecific interstitial pneumonia is uniformly involved. There are two patterns of nonspecific interstitial pneumonia, or NSIP. The first is the cellular pattern, when there is mild to moderate chronic interstitial inflammation involving the alveolar septa, as you can observe it on the right side of the slide. And the other pattern is the fibrosing pattern, where there is interstitial fibrosis with mild to moderate chronic interstitial pneumonia. So the fibrosis trumps inflammation in this case. If we have any fibrotic changes, then we call the NSIP of the fibrosing pattern. And again, this picture illustrates key features of NSIP, more specifically fibrosing NSIP. There is fibrosis, which appears to be of the same age throughout the slide. Some of the alveolar septa are thicker, others are thinner, but everything seems to be of the same age. For those who are interested, there is also a little macrophage accumulation in this corner. Again, a non-specific feature, if you want to call it desquamative interstitial pneumonia or DIP-like reaction, then that would be completely fine. Similar to UIP, or even more so for NSIP than for UIP, there is a list of associated clinical conditions. The most common condition is connective tissue disease. Connective tissue diseases can lead to NSIP pattern, actually quite often. Another would be hypersensitivity pneumonia, also drug toxicity, infection, immunodeficiency, including HIV infection can lead to NSIP. And finally, there is an idiopathic version of NSIP also, which is one of the idiopathic interstitial pneumonias. This table is not to memorize, but just to show you that connective tissue diseases can lead to various interstitial lung diseases, but they also often involve the airways, the pleura, the vessels, and they can also lead to diffuse alveolar hemorrhage. And of course, the column on the left side shows various connective tissue diseases. If we focus on interstitial lung diseases in relation to connective tissue diseases, then we can make a few observations based on this table. First of all, usual interstitial pneumonia is relatively common in rheumatoid arthritis. However, other connective tissue diseases are more often associated with the NSIP pattern. So NSIP is more common in most connective tissue diseases, with the exception of rheumatoid arthritis, where actually usual interstitial pneumonia is more common than NSIP. In addition, as far as interstitial lung diseases are concerned, we can also see sometimes organizing pneumonia pattern, particularly in rheumatoid arthritis and polymyositis, dermatomyositis, diffuse alveolar damage, which is relatively common in polymyositis and dermatomyositis, and systemic lupus erythematosus. In the case of systemic lupus erythematosus, or SLE, it's also known as acute lupus pneumonitis. And unfortunately, it's a deadly disease for these patients. And then LIP is relatively common in Sjögren's syndrome and also in SLE. So some follow-up on this patient. The patient started on azathioprine, which is an immunosuppressive drug, along with low-dose corticosteroids. And 9 years later, the patient is still doing relatively, was still doing relatively okay as far as her pulmonary disease was concerned. However, she did develop pulmonary hypertension. She also had a stroke, most likely related to her atrial fibrillation, and she also had hypertension, and she deceased 12 years after the lung biopsy. Any questions related to this case?
No.
No. If there are no further questions, then we move along. And the next case is a 69-year-old male who presented with progressive dyspnea. As we discussed earlier, that's a common manifestation for patients with interstitial lung disease. Here is the chest CT showing mildly fibrosing interstitial lung disease with some airway components. Again, we see these lines of fibrosis. It seems to be a little more severe in the lower areas of the lung. And then the patient, the patient underwent lung biopsy. Oops. Oh, this is not it. Or so this should be this one. So low magnification view of the patient lung biopsy. If we look at this case at low magnification, that it's obvious that that we have some fibrosis, which is pink, and perhaps also some normal areas of lung tissue. What's different from the first case is that here the fibrosis seems to be around airways. So this looks more like an airway-centered fibrosis, whereas the usual interstitial pneumonia in the first case was more peripheral, involving the subpleural lung tissue as well as the interlobular septa more than other areas of the lung. So at this magnification, we can agree on that this patient has airway-centered fibrosis. So let's look at this a little bit closer. So we definitely have some normal lung tissue as well. Here, there is a lymphoid aggregate. There are no lymphoid follicles, no secondary lymphoid follicles, which would sway us toward a connective tissue disease. Here we see some metaplasia in the peribronchiolar alveoli. So that's called peribronchiolar metaplasia. And what's happening here is that the ciliated epithelium of the bronchioles actually spread into the adjacent alveolar spaces, or they line the adjacent alveolar septa as well. Again, we do have some macrophage accumulation, so we can just probably agree that this is a non-specific finding. If we want to call it DIP, focal DIP reaction, that would be completely fine, but it's not the feature, the main feature of this case. So we have, again, airway-centered fibrosis, some peribronchiolar metaplasia. Let's see what else we have. So we are scanning this slide to find additional features that can help us with the diagnosis. In particular, when we have an airway-centered fibrosis with the inflammation, which contains and also with some lymphoid aggregates, and then this is what we start looking for. So we have a giant cell here, and then here we have microgranuloma, a small non-necrotizing granuloma. So these are rather, especially in the interstitium, these are rather specific for our diagnosis. So just vaguely formed or poorly formed granulomas in a background of airway-centered fibrosis and airway-centered chronic interstitial pneumonia, and some obvious involvement of the bronchioles, which also lead to peribronchiolar metaplasia in this case. So I don't know whether we have any diagnosis for this. This combination of findings are...
Lymphoid aggregate itself is, you commented on at the beginning.
I'm sorry?
Presence of lymphoid aggregates.
So the lymphoid aggregates, lymphoid aggregates we can see in this particular entity, but also in connective tissue disease. Yeah. Once we have secondary lymphoid follicles with germinal centers, that's more specific for connective tissue disease. Lymphoid aggregates by themselves are not a diagnostic finding. So what's important in this case, in addition to all the background features we have looked at, is the presence of these vaguely formed granulomas. So when we see that, then we can make a diagnosis of fibrotic hypersensitivity pneumonia. So the presence of these granulomas helped us to make a diagnosis. So let's see what are the histologic features of hypersensitivity pneumonia, or shortly HP. First of all, it was according to the new classification which came out in 2020, and these are the ATS, JRS, ALAT clinical practice guidelines. So according to that, we are not speaking of acute, subacute, and chronic HP anymore, but we are talking about non-fibrotic and fibrotic HP. So what are the characteristic features or diagnostic features of non-fibrotic or cellular hypersensitivity pneumonia? Bronchiolocentric cellular interstitial pneumonia. So here is a bronchiole or a respiratory bronchiole. One side is lined by respiratory epithelium. It seems to me that on the other side we have alveoli, so that's a respiratory bronchiole. This inflammatory process seems to be centered on this bronchiole. So when we talk about interstitial pneumonia in pulmonary pathology, we just mean inflammation in the alveolar septa. So that's a descriptive diagnosis. In this case, this chronic interstitial pneumonia or cellular interstitial pneumonia is centered on airways. There is also chronic inflammation of the bronchiole wall, and most importantly, again, the presence of this vaguely or poorly formed granuloma helps us make the diagnosis. So that's non-fibrotic or cellular HP. And this is from a case of fibrotic hypersensitivity pneumonia. Again, the process is usually or almost always airway-centered or bronchiolocentric. Here is a bronchiole, and the fibrosis seems to surround that area. And there is also peribronchial metaplasia, similar to our case. Some people also call this lumbartosis. There are channels of Lambert between bronchioles and adjacent alveolar spaces, and these and then the ciliated epithelium creeps through these channels of Lambert and involves the adjacent alveoli. So that's called peribronchial metaplasia. And again, we can make this diagnosis of fibrotic HP if we find these vaguely formed granulomas. If we don't find them, and we just see chronic fibrosing interstitial pneumonia with airway-centered fibrosis, then we can still suggest that this lung disease might be related to a hypersensitivity process, but without these poorly formed non-necrotizing granulomas, we cannot make a definite diagnosis. Airway-centered fibrosis can be caused by other processes as well, for example, microaspiration, etc. Even connective tissue diseases can lead to airway-centered fibrosis. By the way, when we suggest that the patient has hypersensitive pneumonia based on the histologic findings, then the clinicians often say that, well, the patient does not have any known exposure, then we can still insist that our diagnosis is correct, because that's the case in about 50% of the cases. So this is an interesting paper from San Francisco. Oops. It shows that so these patients have been diagnosed with chronic hypersensitivity pneumonia or pneumonitis. By the way, some people use the term pneumonitis, some people say pneumonia. I'm used to saying pneumonia, but maybe pneumonitis is more commonly used. The two terms are interchangeable. Anyway, this paper shows that there are so many ways hypersensitive pneumonia can present. It can present with cellular nonspecific interstitial pneumonia, fibrotic nonspecific interstitial pneumonia, peribronchial inflammation with poorly formed granulomas, bronchiolocentric fibrosis, and it can even present as usually interstitial pneumonia. When we do see these poorly formed granulomas, again, if in each column, the blue areas represent cases with granulomas, and the red areas represent cases without granulomas. So when we do see poorly formed granulomas, then the diagnosis is more straightforward. When we don't see granulomas, the diagnosis may be more difficult. Sometimes if we have a case of NSIP without poorly formed granulomas, we can say that the differential diagnoses include connective tissue diseases, hypersensitivity, pneumonia, drug toxicity, etc. But we cannot make a specific suggestion. If we do see these poorly formed granulomas, then our suggestion can be much stronger. follow-up on this case. The patient did not have a clear exposure, but looking at the radiologic, histologic, and the clinical features, hypersensitive pneumonia was the most likely diagnosis. The patient did receive an anti-fibrotic agent, nintedanib, and 1 year after the biopsy, he is in a fairly stable condition as far as the lung disease is concerned.
I have one question here.
Sure.
Differentiating morphologically between sarcoidosis and fibrotic interstitial pneumonia, since both they have non-necrotizing granuloma, small
Right.
granulomas.
So that's a very good question. Fibrotic hypersensitivity pneumonia is characterized by vaguely formed granulomas, whereas sarcoidosis is characterized by well-formed granulomas, which are usually surrounded by a rim of chronic inflammatory infiltrates. There are some other features that are suggestive of sarcoidosis. These include the presence of coalescent granulomas. So those granulomas in sarcoidosis like to get together, and also the presence of collagen fibrosis is common in cases of sarcoidosis. Again, non-necrotizing granulomas of hypersensitivity pneumonia or hypersensitive pneumonitis, HP, are poorly formed granulomas. They are often represented by collections of epithelial histiocytes or just a couple of giant cells. But it's a very good question. As another comment is that sarcoidosis can also burn out, and then you see the fibrosis in lymphangitic distribution, which means along the pleura, along the interlobular septa, and surrounding the bronchovascular bundles. So this lymphatic distribution is also very characteristic of sarcoidosis. Sometimes what I started to say is that the granulomas in sarcoidosis may slowly disappear with the fibrosis remaining. So when sarcoidosis, when it becomes end stage in some unfortunate cases, granulomas are quite sparse. So we see that in patients who are transplanted for end-stage sarcoidosis.
Thank you.
All right, so the first three cases were for, as you noticed, interstitial lung diseases. So I hope you enjoyed them. And now we are moving away from interstitial lung disease a little bit, looking at some other types of cases. And we are gonna go a little faster with these, I believe. So the next patient is a 46-year-old female who presented with mild intermittent asthma and chest CT findings of diffuse cystic lung disease. So here's the chest CT, which again is very important to us. And it shows these innumerable cysts in the lung parenchyma. Here's another cut, again showing numerous cysts. And here is our slide. At low magnification, some cysts are obvious, like here, perhaps here also. The remaining lung parenchyma seems to be relatively well preserved. So let's look at these cysts a little closer. So, and anyone has submitted a diagnosis yet?
I don't see a diagnosis yet.
I know you told me what the diagnosis was earlier.
Yeah. You are pointing toward the features, so
Yeah.
we should have some diagnosis now, I guess. Let's see.
So these cysts are surrounded by these bundles, and these bundles look like.
Yeah, we have. Yes.
We have. So we have a few correct diagnoses already. So these bundles are reminiscent of embryonal smooth muscle. So if you compare this to the bronchial wall where you also have a smooth muscle, it's a little different, but they say that this looks like embryonal smooth muscle. So if you take a look at this, then you would know how embryonal smooth muscle looks like. The cells are a little bit more epithelioid, or more plump than mature smooth muscle. So when we see this, then we want to do some special stains, and those special stains can lead to our diagnosis, which is, so I'm going back to our presentation. So our diagnosis is lymphangioliomyomatosis, and we are going to list the stains that you can do to confirm the diagnosis in a couple of minutes. So what do we know about lymphangioliomyomatosis, or shortly LAM? It's now it's considered a low-grade neoplasm. So previously it was just considered a cystic lung disease, and it was one of the interstitial lung diseases, and it still presents like that. But now we know that it's a low-grade neoplasm of the perivascular epithelioid cell tumor family. It's an interesting concept. Perivascular epithelioid cells do not exist in among normal circumstances, but we assume that these low-grade neoplasms are differentiated toward perivascular epithelioid cells, and we call them picomas. As we mentioned earlier, they present as cystic lung diseases. Typically, they occur in women in their childbearing years. There are two forms: the sporadic LAM, where other features of the tuberous sclerosis complex are not seen, and it also can present as part of the tuberous sclerosis complex. In those cases, it's called TSC LAM, tuberous sclerosis LAM. Interestingly enough, both the sporadic LAM and the TSC LAM are associated with mutations in either the TSC1 or the TSC2 genes. And histologic features include cystic structures, which are surrounded by bundles of immature smooth muscle. Positive stains include melanoma stains, interestingly enough, including HMB45 and melan A. Beta-catenin is also positive, so is smooth muscle actin and ER and PR. Higher magnification of the immature smooth muscle, again, with this plum smooth muscle cells. 11 years after the lung biopsy, the patient is still doing well, and she's still fairly active, exercising, etc. Unfortunately, in some of the cases, the disease does lead to end-stage lung disease, and some of these patients undergo lung transplantation as well. Any other questions or comments?
No questions.
No questions. So we move to the next case, which is a case of an 84-year-old male with a history of adenocarcinoma in situ. As we know, it's a relatively new concept, but we are not going to dwell on that right now. But more important, the patient also had a right middle lobe nodule. So here is the right middle lobe nodule, relatively small nodule. In radiology, we talk about mass if it's bigger than 3 centimeters. If it's under 3 centimeters, we usually just call it a nodule. And then the nodule was resected. And here is the lesion. We see this relatively homogeneous material and giant cells.
It looks thicker than it should be. Maybe the section is thicker.
Dr. Avia says it's thicker than it should look.
Like there are cracks.
Which is probably she's right. But sometimes lesions don't follow the textbooks, unfortunately. We do have giant cells, and then we have this lymphoid infiltrate as well, with plasma cells. Nice plasma cells. Yeah. So again, lymphoid infiltrates, relatively homogeneous material, more lymphoid infiltrates. So I'm sure we have some diagnosis here. Not yet?
So far.
Okay.
Probably because they are thicker.
Probably because they think this is too easy.
Yeah, I have a diagnosis.
Okay. So, all right. So even if they don't necessarily, and again, giant cells, which is one of the characteristic features. So even if we do think it's a little thicker, we probably still would want to do at least one stain. And if you can choose only one stain, what stain would you use? That's the question. So let's see. We do have a Congo red stain, and oops, and it's nicely red. I can tell you that it also had these apple green polarization characteristics, which I'm not showing right now. So based on this, our diagnosis is nodular pulmonary amyloidosis. Now, if you see, or if you encounter a case of nodular pulmonary amyloidosis, you have to know that most of these cases are actually associated with low-grade B-cell lymphoma. So you have to investigate it a little further. First of all, if we see amyloid, then we usually send it to mass spectrometry. They actually microdissect the Congo red areas and send it through mass spectrometry, and then they can subtype the amyloid. In this case, the peptide profile was consistent with AL amyloid, more specifically lambda type amyloid deposition. Now, deposition of lambda light chains is actually very characteristic of nodular pulmonary amyloidosis. Kappa light chain deposition is more characteristic of light chain deposition disease. So, because most of these cases are actually associated with a low-grade lymphoma, we did do some investigation. Here is CD3, which does show some reactive T lymphocytes. However, the presence of CD20 positive lymphocytes in this number would be unexpected in a reactive process, so that steers us toward lymphoma. Here is on the right side CD138, which highlights plasma cells, and CD79A highlights both plasma cells and the lymphocytes. And here is a lambda stain on the left side with many lambda positive plasma cells, whereas on the right side, the same area shows very few kappa positive plasma cells. So our histologic stains also confirmed the presence of monotypic plasma cells. So based on this, our final diagnosis was nodular pulmonary amyloidosis with lambda-restricted plasma cells and underlying extranodal marginal zone MALT lymphoma. So if no comments on the diagnosis, then we move on to discuss amyloidosis a little more in detail. So amyloid is defined as a proteinaceous substance deposited in the extracellular space, and it's distinguished from non-amyloid deposits by histochemistry, namely a Congo red stain, electron microscopy, or X-ray diffraction. So for practical purposes, whatever is Congo red stain positive, also showing the apple green birefringence, is amyloid, and material that does not stain with Congo red stain is something different, which could be light chain deposition or some other non-amyloid deposit. Now, amyloidosis is a group of diseases characterized by the deposition of amyloid. And here is a nice Congo red stain with apple green birefringence on the right side. So amyloid is composed of amyloid fibril proteins, which are about 95% of the material. These fibril proteins include AL, ATTR, AA, etc. And there is also a non-fibrillar component, which includes serum amyloid P component and other glycoproteins. Now, this table just shows the most common forms of amyloidosis. There are actually dozens of amyloids, dozens of amyloid materials, and consequently dozens forms of amyloidosis have been described. But these are the most common ones. And the current terminology actually uses the fibril proteins to classify amyloidosis. In addition, we also note whether it's systemic or localized. So one of the most common forms is systemic AL. This was previously known as primary amyloidosis. The precursor protein is immunoglobulin light chain. Again, most commonly lambda light chain. The underlying condition is usually some sort of plasma cell dyscrasia, and most organs are involved. The next one is systemic AA. This was used to call secondary amyloidosis. The precursor protein is serum amyloid A, it's usually associated with a chronic inflammatory process, and kidneys are often involved. Next one is systemic wild-type ATTR amyloidosis. This was called previously as age-related or senile amyloidosis. It's the precursor protein is transthyretin, the wild-type transthyretin. Advanced age is one of the predisposing conditions, and heart is commonly involved. Systemic hereditary ATTR was used to call as familial amyloid polyneuropathy. It is the precursor protein is transthyretin variants, and the underlying condition is a mutation in the transthyretin gene, and heart and the peripheral nervous system are often involved. Finally, we got to our case, localized AL amyloidosis, and the precursor protein is immunoglobulin light chain. It's usually associated with mild lymphoma. They say even if you can't find it, it has to be something like that, because we know that the amyloid light chain is monotypic, so that assumes that the plasma cells then that produce it are also monotypic, and monotypic plasma cells equal to lymphoma. Target organs include the tracheobronchial tree, the lungs, and also the urinary bladder, interestingly. Now, if we move to pulmonary amyloidosis, there are three types. The first type is our septal amyloidosis, and that's what the picture shows. the underlying condition typically is systemic AL amyloidosis. So there are rare case reports for each type of pulmonary amyloidosis, but I'm just talking about the more common underlying conditions. So which is for alveolar septal amyloidosis, systemic AL. Here is a higher magnification. Again, hopefully it shows this amyloid material around this vessel and also in the alveolar septa. The next one is our case, nodular, or a similar case, but our case was also nodular pulmonary amyloidosis. It's the underlying condition is localized AL or localized AL-AH amyloid. So in that case, both light chains and heavy chains are deposited. And again, I would like to remind you that these localized AL amyloids, which present in the lung as nodular pulmonary amyloidosis, are often associated with motile lymphoma. One of the features that we can see here is ossification. This is also something that we commonly see. And again, the amyloid deposit and the lymphoid infiltration, just to remind us that we always have to try to confirm that there is a lymphoma in the background, a low-grade B-cell lymphoma in the background. And finally, the third form of pulmonary amyloidosis is tracheobronchial amyloidosis, which again is typically localized AL amyloid. Here is the bronchial wall with a little cartilage here, and higher magnification shows the amyloid deposits, some dystrophic ossification, and again, a lymphoid infiltrates. Some follow-up on this case. So 1 year after surgery, the patient has no clinical symptoms. He is followed with observation and surveillance. So even though most of these patients with localized pulmonary amyloidosis have an underlying lymphoma, it's usually local or localized, and with the surgical removal, the issue is usually resolved. Any questions or comments?
Yeah, I do have a question. Do you need always to see Giant's reaction in the nodular type amyloidosis?
So in pathology, we cannot say always, because there are always exceptions, but most of the time we do see some Giant's reaction. The body recognizes it as something foreign, similar to air. If we have pulmonary interstitial emphysema, the body reacts to the air with Giant cells. So this is just another example.
The other question, like histologically, do you think it looks similar sometimes, between amyloidosis and alveolar proteinosis?
So alveolar proteinosis the amyloidosis is more smooth. The amyloid itself, pulmonary alveolar proteinosis, the material in air spaces is finely granular. So in pulmonary alveolar proteinosis, we also often see cholesterol crystals. So it's a little different, but there is no harm to do the stains if you suspect either of them for a case.
Yeah, that's it.
Any other questions?
No, for this
Okay.
case.
So let's move on to our last case. This is a 58-year-old female who presented with lower back and right hip pain. And this is an ongoing case, so questions still remain, but let's see what we know. So the patient presented with a large 29 bar 28 millimeter lobulated and spiculated mass. They call it a mass. The radiologist did, although technically I believe mass is big enough with 3 centimeters, but this is big enough to call it a mass. In addition, the patient also had some rib lesion, which is shown here. It was described. And here is our slide. This is the last slide. So this is obviously a transbronchial biopsy. I believe actually it was a cryoprobe biopsy. So our interventional pulmonologists have started using cryoprobes, which produce larger samples. They have these cryoprobes that freeze the tissue adjacent to the probe, and they can pull it out. And interestingly enough, we do not have any freezing artifacts. So for those of us who do frozen sections, we know that freezing, at least with a cryostat, can introduce all kinds of artifacts. Interestingly enough, we do not see those artifacts with cryoprobes, and we can see we can get relatively large specimens without any artifacts. So again, this is a cryoprobe specimen. There is some, so this looks like a bronchial wall with some mucosal glands, some muscle walls, some inflammation. But this is this area is where the money is. And what can help in this case is the presence of this myxohyaline material. So that's a characteristic feature of this neoplasm. And then, in addition to that, we do have some cells that appear to be neoplastic, but like these cells. But the key feature that we can that can help us in this small biopsy is the presence of this myxohyaline matrix. So there are these atypical cells, most likely neoplastic, but the myxohyaline matrix is that can help us. Again, some atypical cells, most likely neoplastic. I guess here more. So the question is, what kind of stains we should do to make this diagnosis? Any suggestions? If not, we are moving to the stain.
And we need IHC. Yeah, what type of IHC do you need?
So that I agree. We need
vascular markers.
Exactly.
Yeah.
That's an excellent suggestion. So Here is a CD31 stain, which of course is a vascular marker. You can use obviously other vascular markers as well.
We have the thickness.
This really highlights these atypical cells. So when you have CD31 positive cells, and again, you know that there is this myxohyalin matrix, then probably gives you a diagnosis.
We have a couple of correct diagnoses.
So great. So you guys did really well. The diagnosis is epithelioid hemangioendothelioma. And just a few words about that. As we all know, it's a malignant vascular neoplasm. Formerly, it was known as intravascular bronchioloalveolar tumor, or IFBAT. There are two subtypes recognized. One is with WWTR1 CAMP-TA1 fusion, and the other is one with the YAP1 TFE3 fusion. So these, in cases where we have any doubts, we can do molecular identification of these translocations, and they also have some prognostic consequences. So some centers, they do these molecular studies for to identify the translocations. Localizations include the lung. It could be multiple or solitary. Multiple is actually more common than solitary. In our case, the lesion was solitary in the lung, and the pleura could be also localized or diffuse. Interestingly, most patients with pulmonary epithelioid hemangioendothelioma are females, whereas most patients with pleural epithelioid hemangioendothelioma are males. Histologically, we see this nice central myxohyalin stroma with a thin rim of plum endothelial cells. The nuclei are relatively bland and may have cytoplasmic vacuoles. The clusters seem to fill the alveoli, so the lung architecture seems to be preserved. And positive stains include CD10, factor 8, CD31, and CD34. This is a higher magnification showing the same. And this is the highest magnification where this characteristic feature of cells with cytoplasmic vacuoles is shown. So when this is really a very characteristic feature of epithelioid hemangioendothelioma, the presence of the myxohyalin matrix and the presence of cytoplasmic vacuoles.
Would be good to see RBC inside.
RBC, I guess you could see it
within the vacuole.
Yeah, they try to.
Yeah.
You are exactly right. So they are trying. There might be one there. So they are trying to form capillaries within their cytoplasm. So they try to reproduce their original functions.
Yeah.
Some follow-up. Again, this case is still ongoing. 7 weeks after lung biopsy, the patient underwent a lobectomy, and the diagnosis was confirmed. We did find lymphovascular invasion in the resection specimen. The margins were negative, but metastases involved 5 of 8 intrapulmonary, peribronchial, and hilar lymph nodes. A week later, one of the bone lesions was biopsied, but it was negative for malignancy. It just showed non-specific fibrosis. So the hunt for metastatic disease, which might have been responsible for the patient's original symptoms, which was back pain, is still ongoing. And that's the end of my presentation. And I will be happy to entertain any questions you may have.
Thank you very much, Dr. Andras. We have a good number of attendees and fruitful discussion. I love the cases. Thank you for sending it to us before. It was really excellent a presentation. Thank you for being part of our Journal Club series. And you can find the presentation and the whole video record in our website. Just you can Google Abu Dhabi Surgical Pathology Journal Club, and then you can find it within the SSMC website. You can find all the previous ones as well. And stay tuned for next month Journal Club. Thank you, Dr. Andras.
Thank you, Dr. Ravi.
Thank you.